Our next speaker is John Clark, MD, PhD, who's the Chief Population Health Officer at Sharp Rees Steely Medical Group. And his presentation, you'll see, is because his group is doing very well in these effectiveness performance measures. So, John?
Great, Bill. You can hear me all right?
Yes.
Great, thank you. Next slide, please. First, I have no financial disclosures, but then also wanted to make a point to just acknowledge the Right Care Initiative and really being fundamental in improving the health of our communities, obviously our patients, but even our nation. So thank you for the invitation. Next slide, please. So really, as my colleagues have done a great job in sharing a lot of data and obviously, made the argument with data as to why we're doing what we're doing. On my focus probably mostly is going to be on systems and resources and obviously organizational leadership around blood pressure and hypertension control metrics. We at Sharp obviously have similar programs for diabetes management and statin use for patients with cardiovascular disease, but really just wanted to hone in on just one example of what I see as some of the differentiators for our organization. I'll admit I'm relatively new to Sharp Rees Steely, so a lot of the data that has been presented in the past was before my time. I arrived a little over a year ago, and a lot of the success that we've had has really been for many, many years, and even some of the data I'll show on our performance has even been before I came around, but definitely have some insights into why I think we've been successful. We've definitely had strategies and tools that help us be successful, but I really like to identify the differentiators that I believe to be fundamental in Sharp's success. I trained at Kaiser Los Angeles. I practiced in academic medicine in Texas and California before coming to Sharp a little over a year ago. So it has been interesting just to see some of the differences from different health systems, the way they're organized, what their leadership or strategic goals are, and how that may trickle down to clinics, primary care, as well as patients. But really, as I talk about some of our tools and interventions, I wouldn't say that all of the tools that I think are helpful for Sharp Rees Steely probably would be silver bullets for your organization or every organization. Just like in my medical practice, the hard part is really matching a right tool to the right patient. And I'd say similarly, matching the right tool to the right health system. But I would like to mention a few things and highlight a few things that I definitely think may be differentiators as we go through my agenda today. So next slide, please. Just as background, again, so we are an integrated delivery system as part of Sharp Healthcare, but really I'm with one of the three medical groups. The three big ones are really Sharp Rees Steely Medical Group, Sharp Care, and Sharp Community Medical Group, and we really help take care of the Sharp Healthcare system and their patients, which is about 30% of the inpatient market in San Diego. Next slide, please. And then for our medical group, the Sharp Rees Steely Medical Group, we do have 700 primary care and specialty care providers, 2,800 employees. And again, we are, just in terms of our payer mix, about 70% capitated. So obviously we are taking care of Medicare fee for service, but definitely heavily in HMO, which has been true for us for a long, long time. And I think, we'll explain a little bit of, how organizationally we're structured now as I go through some of that later. Next slide, please. So I'd say an important factor in our ability to really organize our organization's efforts has really been leadership. And what I mean by that in particular is making sure that our leaders, communicate and that our employees truly understand the why of our goals. And so again, this is, an internals, data on our stroke hospitalizations, but we really want, as an organization, our employees, and that can also, we're going to be working directly with patients on the front line to understand why it's important that we really are focusing on cardiovascular disease and specifically with strokes, obviously, hypertension control and blood pressure, monitoring and screening. But in doing so, I think that we're able to support the larger mission of the Right Care Initiative to really reduce preventable disability and death, in this goal. So I think our effectiveness in explaining the why to our patients, but also the why to our employees and creating that culture is really fundamental in our organization. And that's exactly the way we talk about it, or at least when I onboarded last year, and what I've seen, in many of the meetings that I've seen we really try to promote and encourage a true SHARP culture. And part of that is really demanding and delivering high quality care. So I've seen that in new provider onboarding, but even system-wide huddles that include the CMO and the CEO, as well as frontline staff. That again and again, that really culture is developed, and they're constantly explaining the why. Why are we caring about performance metrics like hypertension control? Why do we care about diabetes control? Why do we care about statin medication adherence measures? That they're very effective, and they bring it up again and again when we do have organizational meetings. Next slide, please. And then as I continue to sort of talk about what I believe our organization does well, I do think that we do have clear goals and effective strategies. So the alignment between the goals and the strategies is fundamental. Now, this probably is a no-brainer, but we all have defined priorities, and our organization, I believe, to be effective at communicating those wells, and also making sure that our teams know what to expect and know that we will check in with them on these goals. So part of that expectation is really truly accountability at a variety of different levels in our organizational structure. So whether or not it is giving feedback to chairs of departments, usually frequently those conversations are, what are you doing? How's it going? What are those barriers? But then even as there's separate conversations with leadership, on the health system side, if it's with nursing leadership, staff leadership, clinic leadership, that regularly those same type of metrics and accountability is being brought forth in those conversations about quality measures. And I will talk about some different tactics that our organization uses to be successful, as in the next few slides. But I'll just give these as examples of that coordinated care model that our organization has really put money where their mouth is, and really trying to invest and offload work from primary care. And I'll talk a little bit about it, which are probably similarities to some of the other presentations that you've seen today. Next slide, please. So just as an example, as I said, these are tools. These are not silver bullets, but some of the tools that we think have been helpful for us in our performance and effectiveness is really leadership saying, having patients be able to engage with people in their care team that are not just physicians is fundamental to our success. And that's not just financial success, but I'd say success specifically on metrics and hypertension control. So a good example of that, I would say, is we have primary care nurse clinics that have their own schedules in Epic, not surprisingly, but I'd say these are generally packed for our primary care clinics. So I just gave an example of, I think, like a 2-hour period, one day that I happen to see in our Epic schedule as a screenshot on the right. But these are basically 20-minute visits by nurses. And this was I cherry-picked this. So, but this was an example of literally 6 appointments in a row were for blood pressure checks. And so all the behind the scenes work are clinic staff are running their lists of patients with gaps and actively outreaching to those patients to say, hey, we really want to get a follow-up blood pressure measured. Now that has changed, as my colleagues have mentioned, if it's with Epic tools and other, but again, this has really been our standard of work before we went live in Epic. And I'd say we just went live in Epic recently. This wasn't because of bulk messaging, but this was work that was being done before we went onto Epic last year. So we're relatively new in Epic. And this was work that we've been doing, consistently probably for the past 8 or 9 years in having these nurse clinics. Similarly, we do have a whole population health department, which is what I oversee. And we do have a lot of staff that both either are doing some of these nurse health clinics, so we even have like a population health nurse clinic, but are also helping coordinate. So whether or not it's community health workers, MAs, they're regularly scheduling patients, doing the outreach and scheduling these patients. We also, and this is where it goes to more than just hypertension, we do have a big team. That's why I said our leadership has invested and put their money where their mouth is in things like RN case management, and have really 27 RN case managers in our population health team. Again, that's not just on hypertension, but complex care, diabetes care, sort of advanced primary care. These are all the staff that really in our population health team are really out doing outreach and engaging patients with. Similar to some of the other programs that Dr. Revelo mentioned about texting programs, we have a Center for Health Management that can do health coaching and other things. We definitely lean on remote patient monitoring. I'd say in the patient population that we really have leaned on most has been with our patients that currently are very uncontrolled. As I think you mentioned before, it takes about a month to get that well controlled. These are perfect examples of who we really will want to enroll in our remote patient monitoring programs. That, for example, if a patient were to see me and their blood pressures, measured accurately at like 180 over 100, it's going to take multiple medications. It's going to take time to really get them to goal, if at all. And so those are the patients that we really want to enroll in that remote patient monitoring that not only has the tools, but also has RNs behind the scenes that are reaching out to the patients, doing that helping to try to coordinate that titration of medications for. Obviously, now that we're on Epic, we're trying to take advantage of it. It's been an adjustment, so our performance probably dips some as we're trying to create new clinic workflows and a new EMR, but we are trying to lean on those new Epic tools that some of my colleagues that have been on Epic longer than us have probably did a better job of explaining, but really trying to lean into those tools as well. Next slide, please. Now, I think this is also something that I do think may be somewhat of a differentiator, and I'm probably speaking primarily of my work experience in a few different settings, but this is an example of a looker dashboard that we use specifically on blood pressure rechecks. Now, this is just an example of one of the tools that we believe to be helpful in making sure that our patients are getting an accurate blood pressure measurement in our clinics. We want to make sure if that first reading was elevated, just like all the other health systems, that they are getting it rechecked. And this is just an example of how our dashboard looks. But I'd say one of the things that I would say is in looking at my different employment opportunities in the past has really been how these are used. And so I'd say just having a dashboard, may be helpful, but I think it's just like with any tool for example, patients' health, how you use it is probably the really the key in getting the most effectiveness of that tool. So, I'd say what may differentiate us a little bit from other places is that this data in these dashboards are shared during many different leadership meetings. For example, our CMO or me as a Chief Population Health Officer are regularly reviewing this and displaying this with the chairs of family medicine, internal medicine. We're sharing it at staff meetings, with nursing leadership and other clinic leadership. And this is truly that culture that had been created before I ever got here and is different than what I've seen in some of my other organizations. Even though we had it, it's sort of, what do you do with it? Right. And I'd say this is what I would say that our organization is very strong at, is that we have them, but it's not something that we just created and then sort of left it to wilt. It's something that continues to be something that's a priority for us and needs to be reviewed. And really the teams be held accountable, but also, the leadership's goal is to say, what are those barriers? It's if we're not reaching our goals, it's not like we're blaming someone. We're saying, well, what are those barriers that we really need to tackle? So it's sort of how you use these tools, I think, is what I believe to be a differentiator. The next slide, please. And then another differentiator, and even how we use some of these tools. This is the same looker dashboard, but we actually obviously are able to drill down by certain specialty groups. So this is actually one that is shared with urgent care. And I've seen some conversations in health systems be like, well, urgent care, that's a totally separate beast. They've got sicker patients or other, but that's not true in the Sharp-Reese-Daly world. So this is something that's reviewed with our urgent care providers. And so as an example of engagement with our urgent care teams, we've spent a lot of time and energy in really trying to bring these specialists that may not be so clearly aligned, like cardiology or nephrology or neurology, but really brought them to the table and brought them along for the journey and really trying to get them on board and get their buy-in. And that as of right now, and since I've been here since day one, when I arrived, their leadership was already on board, and the importance of doing this, like the second blood pressure recheck in our urgent care settings, not just because it's helpful for our quality measures and a value-based care organization, but really just the clinically meaningful and clinical importance to it even in an urgent care setting where many patients, unfortunately, are still getting a lot of primary care, but we still, want them as team members and collaborators, and even have incentivized them in certain ways to try to help us be successful in this. Next slide, please. Now, this we've talked before, and other organizations have shared some of their, sort of tip sheets or what those protocols are that they alluded to as well. Ours may not look as fancy as theirs, but I did want to highlight one point about our protocols that we do have standardized and operationalized. Is that even on this, one that we've used in the past, we even include specialty offices, right? And so this is a uniform sort of protocol or process across all of our clinics, not just primary care and not just urgent care. So I'd say it's how you use these tools. And I'd say a good example of this is, most systems have these, but we're really trying to engage and use these same protocols and procedures, in all clinics. So even as we have huddles with, nursing leadership, and nursing leadership is having huddles with all of their clinics, not just primary care, but specialty care as well, they're using these same protocols and procedures across the board. And so as an example, we find this to be helpful that when we have a float nurse, for example, that they're doing the same processes, whether or not they just came from urology or they just came from urgent care or wherever, and then they float into primary care or urgent care that is doing it, that those protocols and procedures are the same. And that's fundamental across the board if you are working in one of our Sharp Reese Daily clinics in Sharp Healthcare. Next slide, please. So really, just as I'm going through, I'd say first, just to recap what may be some of these differentiators, I'd say, in my perspective as a relatively new person to the family, that leadership engagement is very strong, and their ability to communicate hypertension control as well as other cardiovascular metrics is fundamental. And that it goes from the huddles, including CEO, CMO, all the way down to just individual team huddles in a clinic on a morning that are reviewing how their hypertension performance is or how their diabetes care performance is, as well as even the population health teams as we do our monthly huddles as well. The second point is listed here is obviously physician and AP buy-in, and this is not just primary care, but this is both primary care as well as most specialties, if not all, and even how we incentivize as well. And then next thank you, the clear priorities, communication expectations. We really do believe this to be important in the sense of PCPs and providers feel that leadership is really truly investing in them, and that they believe that leadership wants to try to help them be successful and help manage these patient populations with the resources that are given to them. Next 2 points, one more, please. And then, as I mentioned, is we obviously have multiple quality measures, and we really want that communication to be targeted and focused. And so we regularly do talk about our core 4 measures, which hypertension is always one of them, but meaning on our huddles in which we're having all staff involved, it's not every single quality measure. It's really hypertension is one of those 4 that we want to make a point that we're really reviewing and talking about at all times. So that's hypertension, diabetes control, and then the third and fourth sometimes may vary year by year, whether or not this year, for example, may be colorectal cancer screening or child immunizations that we're still reporting out on what we call our core 4 at many of these meetings. And as I mentioned earlier, just that how that communication trickles down to staff. We want that to be a priority, and that any staff member knows that it's a priority for our leadership, and that our leadership is able to communicate that effectively. I believe that's my last slide, but just again wanted to say thank you and happy to take any questions now or in a little bit.